we have opportunity for questions. So what we're really going to focus on tonight is monkeypox and the outbreak for 2022, and helping us to realize that monkeypox is not new, but it's new to our area in terms of the volume of cases that we have right now. It was first discovered in 1959, and prior to the current outbreak, monkeypox was mostly seen in Central and Western Africa in the forest area. It is zoonotic, which means that it can be spread from animals to humans or from humans to animals. And it can be transmitted by contact and droplet exposure if you inhale large droplets. Now, most recently on the CDC page, they also say that it may be contacted by touching surfaces. And that was the most recent thing that came out this week. So this reminds us that every day we have to be cognizant to look on their website and try to get the current information about monkeypox. The virus belongs to what we call the orthopox virus. It's the same virus for smallpox. And so the incubation period of the monkeypox is usually from 6 to 13 days. If you can remember when COVID first came out, the incubation period was somewhere from 2 to 14 days. And now we know that people can become infected even before that 14 days. So the range of this virus is 6 to 13 days, but it can range as far as 21 days. The disease is often self-limiting with symptoms that resolve by themselves within 14 to 21 days. And the symptoms can be mild or severe. The lesions can be very itchy or painful. And the fatality rate or the death rate in the African region was as low as 1 to 10%. So the first case of the current outbreak that we're talking about outside of that endemic area occurred in May of 2022. And if any of you were watching the news, one day it was a few, and then 2 or 3 days later, the numbers had doubled, and it started to increase slowly and until the rate picked up. The source of that case was unknown. The gentleman who developed the rash was somewhere around April 29th. He arrived in the United Kingdom on May 4th. He had departed the day before from Nigeria. And monkeypox was suspected because the people who actually tended to him or evaluated him suspected that he might have monkeypox. So he was immediately isolated. And that just brings to mind that if we suspect that someone has these symptoms, they should isolate immediately, just as they would do with any other virus. And then as of May 11, they did a contact tracing for him, for all the people that he had exposed in the healthcare setting, in the community, and the international flight. And they monitored those people for 21 days. And thankfully, they did not have symptoms at the time. So he had been in Nigeria from April 29th to May 3rd. He left on the 3rd and had arrived in the UK on the 4th. So what happens when someone's exposed? Once that case was isolated and the person was positive, all individuals, regardless of their exposure, whether they were with that person for a short time or long term, they should monitor symptoms for 21 days after that last exposure. And the symptom monitoring can be active or passive. So in our state, I'm in Massachusetts, it depends on the symptoms, but we have to contact the health department if we suspect, as a provider, someone has monkeypox. So it's an active monitoring. And then they talk to the person and get all the history and do all the searches and the contacts. So, but our role as a provider or as a physician is to contact the health department. Health professionals who have cared for or otherwise been in direct or indirect contact with monkeypox patients, even though while we're adhering to the infection control precautions, we are allowed to do self-monitoring. And this is the same criteria that's on the World Health Organization page. There are no work restrictions as long as we're asymptomatic. The contacts who remain asymptomatic can continue routine daily activities, but when the first symptom occurs, they should immediately self-isolate and contact the health department for further guidance, or in the case of the healthcare professionals, our local offices, be it the infection control or whoever's in charge in your institution. And you have someone on from Virginia tonight from the health department who will tell you your guideline and criteria. Mm-hmm. While there are no specific restrictions or activities during the exposure period, the CDC recommends that exposed individuals refrain from donating blood cells, tissue, breast milk, semen, or organs during that entire 21-day period. Mm-hmm. So how does it spread? Initially, you're told direct contact, you have to touch it. The rash at different stages or body fluids from the person. And as I mentioned earlier, there's some new information that came out this week about maybe it's on the contact surfaces, on the cloths, or they've been touched by someone with the monkeypox. And so we're watching that as well. The virus, we talked about the spread from the animal to the human or human to human. And we also know that it can spread for pregnant women to the fetus. So the period of being really contagious is from that first time of symptoms to the rash is fully healed. You want to make sure that you are isolated and you are not exposing other people. So what does the demographics look like? The most recent data, I updated it today from the CDC website, majority are still male. The median age is about 37. And if you look at the graph that I have here, the demographic initially started out mostly white, and there was a gap between the other ethnic groups. But as time has passed up until the 13th of August, you notice that the gap is closing. So anyone can be exposed and anyone can come in contact and be at risk. So it is important that we pay attention to the symptoms that people bring to us so that we know that we're not being exposed. And if in doubt, you want to contact your healthcare provider or whoever's in charge in your state and let them know that you may have been exposed. The most common symptoms is the rash. It usually starts in the genital area, but it can start anywhere. There are many pictures on the web. You see where it's on hands, it's on the trunk of the body. It could be anywhere. But the common place for the rash to start is in the genital area. Wow. People present with being tired, fever and chills, headaches, very similar to COVID. I asked the question in a meeting today we had with ID, should we be testing for both COVID and monkeypox when people don't have a rash and they have these other symptoms? But one of the signs that you see that should really clue you in is that enlarged lymph node. If you see enlarged lymph nodes or you feel that, you want to talk to your healthcare professional. And also, if you're not near your healthcare professional, talk to your public health provider. Muscle aches and itching. Most of these sound like things that we see with COVID or we see with mid-stage flu, except for that rash. And so we want to pay attention to the symptoms we're having. Less frequently, there may be rectal pain, blood in the stools, pain with passing the stool. So these are also things. So really, we're getting a good history to symptoms patients are having, and also what is their track record? Who were they exposed to? Where did they go? Were they in a crowd? Did they travel overseas? Have they been in contact with someone else who is ill who may have traveled? In general, the symptoms for the monkeypox last 2 to 4 weeks. And so we want to pay attention to that as well. So these are just a few pictures that you'll find on the web. If you want to find out what the rash looks like, if you go to Google, type in monkeypox and type images, you'll find a host of images in different stages. One of the things I want you to pay attention to is that very first one, that little vesicle. You know, it looks like a pimple. Yeah. And so someone may come in with that, don't know where it came from. It's very itchy, more itchy than they may say something like, doctor, it itches more than any other pimples I've had, or they notice it and they're not used to having that. You want to make sure you get a good history and also tell them to watch for a few days and isolate to make sure it's not spreading, because they will get more lesions as time passes. So currently in the US, there's over 46,000 cases globally reported in 92 countries. In the US, there are 6 deaths globally, but not in the US. 17 confirmed positive cases in children, and the US is near the top in reporting the monkeypox cases. So 16,000 cases. The states with the most cases are New York, California, Florida, and Texas. And those states are also at the top for the COVID virus. So you want to pay attention to, some people say, I turn the news off. I don't want to know what happens. You want to know what's happening, what's in your neighborhood, so that you can actually protect yourself. Not asking anyone to be a hermit, stay in the house, but you want to know what to look for. So familiarize yourself with what that picture looks like. So what about vaccination? Vaccines are not readily available like they are for COVID at this point, but our government is getting vaccines from other countries and getting vaccines in. New trials are starting in the United States, and it's recommended for those at high risk for the disease, those who know that they've been exposed to people with symptoms, and those who have, been places where they think maybe a family member has the monkeypox. They don't have symptoms yet, but these people are at high risk, so you want to make sure that they have access. If you notice, when we first got the vaccines in our country, a lot of them went to places like New York and California because people have been exposed. If you're in contact with someone who has monkeypox, then you were identified as possibly exposed, then you want to seek out the vaccination. We do not give the vaccination in our hospital, but we direct people to the health department, and they have a setup in various regions to deliver the vaccination. If you had a sexual partner within the last 2 weeks who has monkeypox, you want to seek out the vaccination. If you have multiple partners, you might be eligible for the vaccination. I encourage you to call your local health department. If you're a lab or healthcare worker who's around the virus, including in the animals, you also may want to be vaccinated. And I'm sure new guidelines will come out shortly. I saw in the news last night, we're getting another 1.6 million doses from somewhere. So keep watching your news. So what about testing? Any suspected case of monkeypox should immediately be reported to your local health department. Now, if your guidelines are different in your city or in your organization where you work and you report it there first, then please follow those guidelines. We're required to report it to our infectious disease specialists at our institution, but we also have to report it, especially the leaders, to the health department. If tests are available, test. If patients have clinical symptoms consistent with monkeypox, test. What I was told today is we have the test. We may not have all the vaccines, but we have the test. So if you are suspicious, do the test. So it's positive. So now what? We talked about isolating away from others, and we want to stay isolated to all the scabs are gone. If you have a rash and you have lesions and you're still getting new lesions, then you need to stay in isolation until the scabs are healed. When do you discontinue the isolation? If you're not sure, call a medical provider, especially in this day where we have so much telehealth. You can call your provider and talk to them as long as it's not in a private area where the rash is, and make sure that you should stay isolated. Some living facilities may be able to provide isolation on site and others may not. There are some instances on the web, and I watch this monkeypox news every day, where they, in places where people live together, if multiple people have it, they're allowed to sit in the same room. But otherwise, you want to stay isolated from anyone who is positive for monkeypox. You want to avoid activities that could spread dry material from the lesions, which is like use of fans, dry dusting, sweeping, or vacuuming in those areas where you have multiple people positive. And you really just want to be cautious of the surfaces. There's a lot of questions to be asked about sheets and blankets and plastic cover. It's on the CDC website, but it's not proven yet, but we need to be cautious about it. And of course, your PPE, you want to make sure if you're in a place where you're caring for people that you wear your gowns, your gloves, and your eye protection and a good mask. The question is still in whether we wear the surgical blue mask or we wear the N95s, and hopefully in a day or two, we'll have that answer. So what's the treatment? No known treatment where we can give a medicine and it automatically goes away. Of course, you're going to treat the symptoms. If someone's itching, we'll probably give them something for the itching. Or if someone's having pain, we'll probably treat the pain. But there's not a treatment itself for the monkeypox. There is a medicine, an antiviral that we use for smallpox. And it's been used for smallpox that may be tried as well, and it's called TPOXX. And it's most likely going to be given to people who are more severely ill or who have weakened immune systems. You want to make sure you talk to your medical provider for specific treatment options, and additional treatment information is on the CDC webpage, and it's more like supportive therapy. That's all I have for you about monkeypox. Any questions?
Thank you. Thank you, Dr. Fowler. That was very informative. And I do have questions. I'm going to ask other people, if you have questions, put them in the chat. We are now at about 26 minutes after 8, and I want to make sure that Dr. Viray has enough time to share with us the information she has tonight. So we're going to move the Q&A to after our next speaker.
Okay.
So Dr. Melissa Viray is an infectious disease specialist, and she is the Deputy Director of the Richmond Henrico Health Department. She's going to talk to us next about COVID-19, give us a COVID update. And I've asked her if she has it available to her to share with us what should we be doing to prepare for returning to school. So let me see if I can get her in now.
No, I'm right here. I'm here.
Oh, okay. Are you able to share your screen?
I am, but let me, I would love if you would give me just maybe, I know we're running on time. I just wanted to add a couple of local thoughts. Dr. Fowler is from Massachusetts. Thank you for speaking. I just wanted to add a couple of additional thoughts from our aspect, given the Virginia perspective regarding monkeypox, if we had a moment.
Sure, go ahead. That's what we want you to do. We wanted to get an idea of what's going on across the country. So I'm very thankful that she's sharing with us what they're doing up at UMass, where she's running a COVID clinic and now writing newsletters for the physicians about monkeypox and COVID. But we did want you to come on, Dr. Viray, to bring it a little closer to home. What's happening here in Virginia, and what do we need to do as we are going back to school, opening up our churches, and having more in-person meetings. So thank you for joining us and sharing your knowledge.
Sure. Let me start with a little bit. My slides are all COVID based, but let me start with a couple of local thoughts around monkeypox. We are seeing cases here in Virginia, primarily in the northern part of the state, but also here in the central region. We're at 295 cases here in Virginia right now, all told. Primarily, we are seeing them in men, and the overwhelming majority of our cases have been in our bi, gay, and men who have sex with men. It is not something that we consider a sexually transmitted disease, more that the close contact that you see with sexual activity is the close kind of contact that will also transmit monkeypox. I think what a couple of things I'd like to add are that here in Virginia, we are encouraging providers to test for monkeypox virus if they see patients in clinic. If you see patients with a genital rash, if you see STI patients, it's very likely to come into your clinic. Please contact your local health department. We can talk to you about what needs to happen in your clinic so that you all feel comfortable testing for monkeypox. There needs to be a rash to test. If you don't have a rash, nothing to test. So it's important that you tell your patients, that you tell your families, that you tell your folks that, if you're worried about monkeypox, there has to be something to test. There is no serum, there's no serology that we use right now. There's nothing that we have to have a lesion in order to test. But there is a test available. We are encouraging providers to use it if you are an at-risk individual. And again, as I mentioned, the majority of our cases right now are in, again, bi, gay, men who have sex with men, trans women, and non-binary folks who are assigned male at birth who have sex with men, often with multiple or anonymous partners. We are, again, it is not an STI disease. It's not a sexually transmitted infection. That is, but if you know or you are an at-risk individual, we encourage folks to know the symptoms that Dr. Fowler went over very nicely, know about the rash, know what the rash looks like, know when to call for help, know when to see your provider, to go ahead and seek out help. If in your family, in your parish, in your church, you support individuals who are at risk, make sure that they know, and that we're also trying to avoid, we don't want people to feel that this is a stigmatizing disease. This is not something that is selecting out a particular population. It just happens to be the kind of contact that they're experiencing, that we see this happening. We really want individuals to feel supported and that they can, go ahead and seek out care for these at their primary care provider, at their local health district, at an urgent care clinic. So we have an increasing number of urgent care clinics and providers who are providing testing. So we're hoping that people seek out care. Number two is that we are offering vaccine to those who are most at risk here in Virginia. It is a little frustrating for folks because it's a little frustrating for folks. Can I mute that? No. It's a little frustrating because I know that we in the Richmond. How about now? Nope, I'm still muted. Nope.
Okay.
Oh, there you go. We in the Richmond area are still trying to get through our most at-risk folks, and in other areas, I know they might have more access, so they've been able to even expand their access in alignment with the new CDC recommendations to include other risk groups as well. We are still working on our list of at-risk folks. And so we ask people to be patient as we reach out to individuals and say, offer them vaccine. We have many health districts across the state, if not all of them at this point, do have a vaccine interest form on their websites. We in Richmond and Henrico have one as well, that individuals can sign up if they are an at-risk individual, or they, and they are identified with it. Or if they identify in one of those risk groups, please go to the vaccine interest form and fill out the form. Let us know that you're interested in getting vaccine, so we can reach out to you to get vaccine against monkeypox. If you know, or your family, if you are an at-risk individual, you have a family member who is an at-risk individual, encourage them to seek out vaccination. This is something that can protect them, can protect others. I'm hearing a lot from the community that this can be an incredibly uncomfortable disease, and we would love to avoid both its transmission and for individuals to have to experience it. And that is, there's more information on all of our websites. All of the local health districts have posted information on how to get vaccinated, what it looks like. So go ahead and go to VDH's website, go to our local health district websites. That was just a tiny bit of what I just wanted to add on to what Dr. Fowler already nicely covered. But let me also go ahead and talk more and switch topics and move on to COVID-19. Oh, but I can't share my screen anymore. Oh no. Oh no.
Okay, I'll put here. Oh, no.
But I tried it. Maybe I did try it earlier. No, I didn't try it earlier. I mentioned I forgot.
Okay.
Oh, no, let's try it now. Yes. Perfect. Got it? We there? See my screen?
Yes, we can see your screen.
Perfect. All right. So back to COVID-19. I know y'all are very tired of hearing us talk about COVID-19, but guess what? It's not going anywhere. Sorry to say that. So just a little bit around where are we now? What does that mean now? And a little bit on where are we at with vaccines, where are we at with boosters, where are we at with all that good stuff. And then what does that mean? I know a couple of words on new CDC recommendations and what does that mean for our kids, our families, our churches. Oh, yeah. So I'm going to talk a little bit about what we're seeing. I didn't realize, my apologies, Dr. Hamilton Stubbs. I thought we were talking to the local chapter. I have primarily Richmond Henrico data, but I will talk a little bit about how that also works with our Virginia data. I'll talk a little bit about boosters, testing, and updated guidance. Sorry again that this is not statewide, my apologies, but at least what we're seeing is a number of counties, including Richmond and Henrico here in Central Virginia, do continue to have high and medium CDC COVID community levels. CDC community levels are, they look at both case rates, hospitalizations, and the burden of illness in the community to kind of say, are we at high, are we at medium, are we at low, you know, to kind of let folks be aware of and make decisions based on their risk factors. Right now in Richmond and Henrico, we are still in high and medium. Although I think the good news for us, and something that informs the new CDC guidance, is that if you look at, this is our metro region hospitalizations, we have what's going on in terms of our hospitalizations in green, and then our ICU bed use in orange, and then our ventilator use within the ICUs in blue. And I think what you see here is, this is just starting from January of this year. What you see here is, although we've had cases, we've been seeing cases, we are not seeing the kinds of burdens of disease, of hospitalization that we saw in January, certainly nothing on the order of what we saw during Delta in 2021, or even with the initial rush of COVID infections back in the spring of was that 2020? Gosh, that was so long ago. But we are, I think it's important to notice though, that we are, you know, it's a bit of what I call a burble. It's kind of burbling back and forth, but I think it's important to notice here that we are seeing a slow, steady increase. It's slow, it's nothing near what we saw before, but it's just there to remind us that, you know what, COVID is still here. It is still posing a risk to our communities. There are still people who are getting seriously sick from this, and we can't necessarily say it's by the, you know, leave it by the wayside. It is good news though that we are not seeing the kind of hospitalizations that we saw back in even earlier this year. Looking at what we know about our cases, again, my apologies, this is local data, but we do know, looking at who's getting sick, that it, just like in, you know, what we've seen elsewhere, we know that our communities of color do tend to carry a burden of the disease. That's what we saw in particular in our Black communities throughout this pandemic, and it's something we continue to see now. It is something that we know is not just related to infection, but a lot of the other factors that go into social determinants of health, and things that we need to work on from a root cause. In addition to working on transmission, we need to look at what are the reasons why, you know, the underpinning reasons why so many of our communities of color get hit hard with these kinds of pandemics. And that's something that we continue to work on alongside COVID. This is Henrico. Henrico is a slightly different demographic. This is just who is getting sick. In Henrico, slightly more less urban area in Virginia. That's for Dr. Fowler. She's not from here. Looking at vaccination, we do see some inequities. We do see a different uptick when it comes to who is taking vaccine. And this continues to be something that we try to work on with our communities, but it has been difficult. In particular, our communities of color, and really for our youth. Our uptick of vaccine in our I would say our young males, or our young individuals, not just males, our 18s to 25s. And then even in our under 15s, really just is not as high as we would like it to be. This will continue to pose a risk. I think people may not be as worried that they're going to get sick. And then our kids, maybe parents are worried about giving their kids the vaccine, but it does continue to pose a risk for families as we move forward, because we aren't seeing the kind of primary vaccine even uptake that we would like to best protect our communities from ongoing infection, ongoing disease, and that slow increasing rise in more severe disease that we're seeing just as things go on. Same thing for Henrico. And it's a reminder that everyone is eligible, almost everyone. Are under 6 months, there's a small window, folks. Almost everyone is eligible for a primary series COVID-19 vaccine. And we encourage folks to, you know, if you haven't already done it, there's no time like the present. It's not too late. Now is a lovely and great time to get vaccinated. and try to avoid, the next round of infections. Let's remind our immune systems, let's go ahead and get those boosters, get that primary series, do something that is less harmful with vaccine than actual infection, to remind our immune systems what this virus is, to protect us against severe illness from whatever's coming down the pipeline as the next round of variants comes, makes its way through. We continue to have a menu of vaccination options. Pfizer is now available for 6 months and up. Moderna is available for 12 and up. Novavax is the new player on the field. It's more or less, we no longer really offer Johnson & Johnson, but Novavax is, it's using a platform that is similar to the vaccines that we have from way back when, like hepatitis B vaccines, but it is for COVID-19, and it's available for those who are 12 and up. And that's a primary series vaccine as well that is now available in a lot of different places, including health departments. So whatever it may be, if that's a concern for your family, we encourage folks to go ahead and get vaccinated and or boosted. Boosters are available for those who are post their primary series. And again, we encourage that as well. We continue to testing. The at-home test world has meant that we are not seeing as much in the way of PCR testing. And it means that there's not as much demand for PCR testing, but certainly lots of us at the health department at urgent cares still offer the COVID-19 test. But moreover, we are frequently, at least in Richmond, Henrico, and other parts of the state, we are freely, we are sharing, giving out at-home tests so that individuals who are either symptomatic or recently exposed can go ahead and get tested, because we still encourage folks, if you think you have COVID-19, if you think you were, you have some symptoms, you're not sure, go ahead and get tested. And don't forget that because we are with these rapid at-home tests, because we know that they're just not as sensitive sometimes as the PCR test, we do encourage folks to go ahead and test more than once. In fact, if it's negative, we may encourage you to test a couple of times so that we can maximize that, make sure that we make up for the lack of sensitivity in these at-home tests. In the fall, perhaps as soon as near future, in the very near future, Pfizer and Moderna have been in discussions with, they're planning to submit, and I think Pfizer's already submitted, filing with FDA to get emergency use authorization for the next round of boosters. This time, what they're looking at is what they're calling a bivalent booster, meaning it's got the virus, it's got the vaccine that the primary series that's been what's been offered since January of 2021, and they're also formulating a new vaccine strain that is based on one of the later Omicron subvariants, BA4 and 5, so that there's something that is more similar to what's circulating now, alongside the original strain that's in there. And our current understanding is that these are going to be available as boosters and not as primary series, but for those who have already been vaccinated, to offer a little extra coverage for those who have already been vaccinated, that has both the original variant, the original strain, and this new, closer to what's been around recently strain in it, so that your body can be reminded, hey, this is what you need to be looking out for so that you don't get severe disease. We have been hearing from CDC that FDA's got to look at it and determine whether or not they want to authorize it. ACIP, CDC, and their advisory committee for immunization practices have to look at it and see what's appropriate, whether or not it's appropriate to recommend it. But we are already in the process of saying, all right, if all that works out, how are we going to roll that out? So if that all works out and that all happens, then we would anticipate that happening as soon as in the next couple of weeks. It could happen very soon. Again, this all depends on the FDA and CDC, but we could see this new bivalent booster coming into the communities in the very near future. This would also, again, be just like the other ones, out at your providers' offices, in the pharmacies, and at the local health districts. So this could be coming into your communities in the very near future. I do want to take a moment to talk about, actually before we'll go here. I think talking about new CDC recommendations, I think a lot of folks have asked, what does it mean that CDC is kind of stepping back on some of the recommendations that we've had for the last 2 years around COVID and COVID mitigations, and why don't we need to distance? What's going on here? I think it's a combination of things. I think what we're looking at is that right now, CDC still says, if you have symptoms, test, and if you're sick, stay home. I think that's no one's changed that. That's still the same thing. I think what we're seeing now is it's, as we're trying to come to a new normal, a middle ground, it's one of those things where it says, all right, if you have been exposed, go ahead and, wear a mask, try to, be good around trying to protect others and take a test. But we're trying to, it's a balance between the fact that we know that we're seeing fewer hospitalizations now than we were before. We're seeing less of a burden on that community. And we know that there is a substantive impact in requiring that people not go out and not be able to work and learn and earn a living that has had a pretty substantive impact on our lives and the lives of our loved ones over the past 2 years. So it's a balance of trying to we continue to try to come to this new normal that is protecting folks from those most severe outcomes, while at the same time making sure that folks aren't having to make hard choices about, do I put food on the table, or do I try to avoid transmitting disease to others? And so this is, knowing what we've got, we're trying to find that middle ground to help people to stay as safe as they can and still be able to live their lives fully. But all that say, we still say, if you have COVID, please stay home. What does this mean for schools and churches and for our communities, though? I think what that means is that it is not, we are not out of the woods yet with COVID. There can still, it is, a lot of different experts say a lot of different things. A lot of really smart people have weighed in a lot of different ways about, whether or not a different variant is going to knock us out of the park again. We don't know. I think we have to keep our eyes open to say there might be another variant that comes through that, unlike, BA4 and 5, is not milder. There might be something that comes down the pipeline that is big and bad the way that some of the initial variants were. But right now, what we're looking at is, it's not that we can treat, it's still not common cold. It's a little more severe than the common cold, and we need to treat it like it's a little more severe than the common cold, because there are, but I think it's a little, we can take a step back from some of the stuff we were doing in 2020. We're in a different place now. We have vaccine, we have, we're seeing fewer hospitalizations, and it's, I think people should definitely consider their own individual risk when it comes to going out in public, going to services. You may want to yourself wear a mask. You may want to encourage your kids to wear a mask in school. I think that but it does come down to as the same things that we would do for, or for pertussis and influenza, where it's, yes, absolutely. When you're sick, stay home. When your kids are sick, they should really be staying home. No one else needs to get that. Whether it's COVID, influenza, norovirus, Shigella, no one else needs that. Keep your kids up to date and vaccinated. Keep yourself up to date and vaccinated. All of these things can, protect our communities as we're, working to find that middle ground to say, is it okay to go to church? I think depending on who you are and what your risks are and what the environment is, you have to judge your own comfort level. I think we are seeing that right now, perhaps there is, while we still have some infections going around, we have some hospitalizations. We're not seeing a lot of hospitalizations, but if you're someone who has a weakened immune system, you might want to not be in the most crowded part of the service. You might want to make sure that that your family is vaccinated. You might want to make sure that, people don't come to visit when they're sick, because you probably should do that anyway if you have a weaker immune system. And so one of these things is just, how does this meld into the flow of our lives? How does this meld into the flow of the way that we do things so that we're not in COVID-landia for the rest of our lives? And how does this meld into how does this make sense for us as a community and as people to live our lives alongside this virus? I feel like I've been saying that for the better part of a year, but it continues to be true. This is us learning how to live with this virus. And so I think right now, again, if you do have COVID, from the day you first test positive or when you first develop symptoms, you need to stay home and away from others for 5 days. If you're at risk for severe illness, you're a little older, you have some other conditions like diabetes or lung disease, you talk to your doctor about whether or not you need to get Paxlovid or another treatment course to stave off the potential for severe disease. If you are otherwise getting better, you've broken your fever at 5 days, and you haven't had a fever for 24 hours without any Tylenol on board, you should still wear a mask around others, but you don't have to stay at home by yourself alone from everyone else for the next 5 days. But we encourage at least until day 11, keep wearing that mask, and perhaps don't visit folks who are vulnerable to getting severe illness to protect them. This isn't that different from what we're doing for the last 10 years. Not 10 years. It feels like the last 10 years, but it's really only the last 2 years. If you were exposed to COVID, you don't have to quarantine, but wear a mask around others and get tested at day 5 or 6 days to see if you may have acquired COVID, and then go ahead and isolate. This is maybe the only really big, one of the bigger changes that we saw come out. And it's, a lot of it is saying, how are we trying to blend what is tolerable for people with what we're seeing in terms of the severity of COVID infections here in our communities. I think that's all I have. So now I know I talked a lot. Let me say, do people have questions?
Thank you. Thank you. That was very informative. And I do want to apologize because it did start out as just a program for Henrico, but I had so many people contacting me about monkeypox and afraid to send their kids back to school. I thought it would just be more efficient if we made it into an open state.
That's fine. That's fine. It's fine. I apologize. I only had Henrico Richmond slots.
That's fine.
But a lot of these things are still true for everyone else. I think right now, families and parents should absolutely think about their own risks and perhaps talking to their kids about and say, it's okay to send your kids to school with a mask. It's okay to make sure your kids are know how to wash their hands properly. That's absolutely still a good thing to do, and not just for COVID either, but for all the other things that are going around and that will come around the school. We haven't seen a really big flu season in a while, and we're probably due. So I think there are lots of things that are probably going to go around this winter and this fall that those same practices that are going to be good to prevent COVID in your kids that you're sending to school are going to be good for those other things too.
Right. Well, I want to take a few questions, and then if we have any time left, I would like to move on to just touch on long COVID. And maybe Dr. Fowler will share with me, and you too, Dr. Viray, some of their experiences with dealing with people who've had long COVID. I think that we get this sense that it is like the common cold and we're going to get over it, because so many of the people that we know did get over it, but there are a few people who didn't, and we should be aware of that. So let's open up your mics, ask some questions about monkeypox if you have any, or what we've already talked about with COVID. I'm going to, okay. Just state your name, and if you're with a branch of the NAACP, give me the name of the branch, please.
Dr. Stubb.
Okay, Miss Boyd, how are you?
Hi, how are you? I put my question on the chat.
Okay. Do you want to just want to state it for us?
Okay.
I'm looking for it. Oh, here it is. I see it.
Okay, thanks.
Are we still seeing COVID spread because people are not being vaccinated, or are the new cases due to mutations of the original virus?
Both. Sorry, the answer is both ends. So what we know now is that there certainly, I think, it's not just people being unvaccinated, although the concern that we have is that a lot of those who are unvaccinated have perhaps already seen at least one round of natural infection. But we also know is that, and that's not everyone, but we also know that with the way that the virus is mutated, that we do see reinfection even in, or vaccinated, breakthrough infection, even in those who have been vaccinated and boosted, the thing that we continue to push for is to push for people to stay vaccinated, to stay out of the hospital, because that's really what the vaccine is best at, is keeping people alive and out of the hospital. And I think that's where that's what we're really looking for. So it is a little bit of both, a little both ends.
Okay.
All right, thank you.
We have another comment from Minister Brower, and I have noticed this, that the cost for testing is being shifted to insurance companies and individuals. For example, some of the facilities that were doing free COVID testing are now charging a facility fee, even if you don't go into the facility. What can people do who don't have the money for that facility fee, but they do have insurance and they want to be tested because they think they may have COVID?
So I think one of the things that changed this spring is that the funding to support COVID testing went away. And it is an unfortunate truth. And we saw it coming, and I mean, it was a federal thing. It wasn't anything we could control. One of the things that we have done to try and offset that, I can't speak to facility fees. I don't know enough about how that plays out, facility fees versus the visit fees versus the whatever fees. I know that two of the things that we, at least in Virginia, have been looking to do to offset that is, number one, make at-home testing as available as humanly possible. And number two, we do, at least locally, and I know of others that other districts are also doing, we do still offer PCR testing in case folks want it. We're not finding that people are taking us up on that. We're not finding that people are wanting it, but we're finding that people would rather do an at-home test, and that's okay. But we are still offering it just in case people do. We're just not finding a lot of people taking us up on it locally. I think it is really about, we are trying as much as we can to saturate the population with at-home tests, so that if you can't get out and you don't, then go ahead and get that done. And then if you need to go ahead and get, you want to go ahead and get confirmation, you want to go ahead and get that PCR testing, we are trying to make a couple other options available. But when that federal funding was cut, a little bit out of our control. So we've just tried to work around it and try to get other ways to help people make sure they still have access to testing, because we
Thank you. Let's see, I have a couple of questions here. I'm going to start with the home test kits have an expiration date, and that expiration date seems to come around pretty quickly. So I've read that there's been some kind of adjustment where people can still use it even if their kit's expiration date has expired, if it's passed.
It depends on the test. It depends on the maker. And it was some of the tests, but not others. And it's not. And so what I would say to folks is that go to the website of the maker of the test, because some of them didn't. Some of them I have not seen expiration extensions on, and some of them I have. And I would say the best bet that you'll have is to go to the manufacturer's website and see if they have something posted on expiry extensions, because it's been enough of there's been enough variability that I can't make a blanket statement.
What kind of precautions?
Dr. Stubb, can I ask a question?
Oh, sure. Go ahead, Mr. Brower.
So the other thing, in addition to the issue of testing cost, I believe the Biden administration is also moving to make the cost of the actual vaccination covered by, no longer paid by the federal government, but shifting that to the insurance companies. And if you don't have insurance, that means shifting it to you as an individual. And so as we as African Americans are underinsured, it seems kind of an imperative that while it is being paid for by the government, we need to aggressively try to reduce vaccine hesitancy and get more shots in the arms of our community.
I would also I cannot make any political statements, but I would encourage folks to speak with their elected officials about the importance of ongoing support for COVID, for financing COVID vaccine. And that's not a political statement because it doesn't, actually it's fair because it doesn't matter who you voted for. It is something that it's important that our elected officials at all levels, but in particular go as far up as we can go, understand the consequences of cutting federal funding to purchase vaccines and what that means for our communities. So I would just echo what Mr. Brower said, and then tack on a little bit of extra.
But you know, we could use the idea that the funds are going to be cut as a forcing function to raise the level of concern on getting the vaccinations, and not that this ain't going to be free forever, y'all. So you need to go ahead and get it done. You know, both ends.
That's a very good point. And I think that's a good talking point for us. We will be having a chance to get in front of people with the boosters that are scheduled. Dr. Viray, can you tell us about that? And Dr. Fowler, I still hope if you're here, you can close us out with just a couple cases of long COVID. Explain what it is, because we have one question on that. But what about that booster that's supposed to come? Is it coming in September, October? Who's eligible? Is it free?
Mm-hmm.
Get it?
That's the bivalent vaccine that I was talking about. Hopefully, I have heard, y'all don't remember me saying every time I said, oh, it's going to be so, you know, this month I was wrong because it was a different month. Every time I do this, it's wrong. It's going to be like that again. I would say we are ready for it to be we are prepared for it to be ready as early as September. However, the usual steps still have to happen. So FDA still has to authorize it. CDC's Advisory Committee on Immunization Practices still has to evaluate it and they are ready and prepared to do it, you know, on weekends and in the evenings as they need to, but those steps still have to go. But we are ready for it to happen as soon as September. So it depends on when the filing happens. Basically, it depends on when the manufacturers submit all their paperwork and how long it takes FDA to evaluate and things like that.
We may run into some of the same vaccine hesitancies when we start to address monkeypox.
Yeah.
So we have brochures that our branches could get from the health department, because there is information on the website, but it's not very practical for us to print it out and distribute printed out copies that we're making as individuals at our health fairs.
We have flyerage that we can, let me make a note to my.
Okay, and then I'll share that information with our health committee chairs and the ministers' wives. I just want to acknowledge the president of the Virginia Association of Ministers' Wives and Ministers' Widows, President Ellen Jamerson, who joined us tonight. Thank you so much, Madam President. And I also want to acknowledge Pastor John Henry Scott, who has joined the health committee to help us with community liaison, and he's here tonight. We have a couple of people from our Religious Affairs Committee, because we are trying to see how our branches can work with the health departments to increase awareness about monkeypox and then the vaccines and deal with the vaccine hesitancy. So I want to acknowledge Minister Carl Brower and Elder Deborah Brown, who joined us from the Religious Affairs Committee. And all of you are very important, and I thank each and every one of you for coming out tonight. I love all of the support that we've been getting from our branches. We have some people here who have worked very closely to open up clinics across Virginia and make the vaccine available to people living in rural areas. And one of those people is Miss Brenda Dixon. She's president down there in Gloucester. We don't have our Albemarle County president with us now, but Mr. Winston has done a fantastic job of steering us. We have so many people who want to work with the health department. So we are hoping that we are able to do that. And we don't have a lot of providers to give the shots, but we understand that there is a there's a medical team that once we have a site, we can coordinate with them to give the medical injections. And Hanover is having a health fair October 1st. That'd be a great time for us to try to get some information out so we can address vaccine hesitancy, as Minister Brower has said, but also let people know where they can go and what they should be doing to not only return to school and churches and in-person meetings, but to be able to stay there, because we haven't gotten together and started spreading this with our community and making it so that we all have to go back inside and start isolating again. So there's a couple questions here that I think we need to address before we go. The monkeypox vaccine, are there any known side effects that people need to be aware of?
The vaccine we're using right now is called Jynneos. And I think one of the things that you might have heard about way back when, this wasn't even that long ago, the smallpox vaccine that we used to use caused that weird little stabby thing. And then, you know, certain people couldn't get it, pregnant women couldn't get it. That's not the vaccine that we're using now. It's the vaccine we're using now is for both smallpox and monkeypox, called Jynneos. There are not a lot in the way of side effects for this. What with the intradermal shot, there might be a bit more soreness and tightness at the injection site, but I don't think that's kind of unexpected when you're getting an injection. But there are not a ton of contraindications, and there are not a ton of side effects that it's not going to be like that COVID vaccine where you knew you were going to be sick, you were going to not feel well the next day. It's more along the lines of what we're used to when it comes to just getting your vaccine.
Thank you. And I want to answer the question in the chat, what is long COVID? I'm going to ask Dr. Fowler if she will explain that, and then tell us a little bit about your experience working with some of your patients. I know you have to protect their privacy, so we're not asking for you to violate HIPAA laws, but some of the experience that you've had working with people and things that we need to be aware of. And I just see the hand from Ms. Dixon. After Dr. Fowler, if we have more time, Ms. Dixon, I'll let you ask your question if you don't mind.
So the long COVID usually occurs more than 4 weeks after having the COVID virus. And patients can have anything from cognitive deficits where they can't remember things, or their thought process is cloudy, and we call that brain fog, to severe cognitive deficits. And I've also had patients who have like muscular and motor deficits. They can't walk well. It's almost like they've become crippled. And we really don't know the root of that. We usually do evaluation like you would for anyone who went through that for stroke, and just looking for a diagnosis to find out what's really happening. And then when all of those diagnoses come back normal, and so he's really doing routine things like going to therapy. But it's kind of sad to see my patients be normal one day and then in a couple of weeks not able to do these things. So the common things that we see are the brain fogs, the muscle weakness, and also the confusion. But there's also a new group of people with long COVID who are getting gastroparesis, so they're having a lot of nausea, vomiting. I am following someone who's lost over 70 pounds, and we can't find a reason. So it's a lot.
And the fatigue, there's a lot of folks who are just having this really profound fatigue.
Mm-hmm.
And we unfortunately just don't, it needs better definitions. We need more experience with it, and we need more information and more studies. And it's just, unfortunately, we're all learning together on this. And I think it's really frustrating for families and for patients because we don't have answers and we don't have treatments that are other than like Dr. Fowler was saying, we have supportive treatment. And I think this actually goes back to, oh, there you go. I was actually just going to reference you, Mr. Brower. The comments that when we're talking to folks about vaccination, people don't talk about the long-term consequences. People don't think about the long-term consequences. We are seeing this syndrome of really, we still don't understand well, but we know it's happening. and we think it's gonna be a problem for folks for a minute. And we hope that we don't, for a while there, this is actually nodding to Mr. Brower's comment in, there were some studies, I don't know if Dr. Fowler has something on this. There were some studies that were saying perhaps their vaccination may avert it, but then there was another one that contradicted it. So the people are going back and forth as to whether or not vaccination has an impact on it or not. And so that's where I think we will probably know more long after we want to know. So I don't think we can comment on that because I think studies have been conflicting.
Yes, and I have patients who have not been vaccinated, but I have just as many patients who have been vaccinated, had boosters and everything, and had COVID again.
Yeah.
In the midst of the long COVID. So the people that I've followed the longest are already more than a year out.
I want to have Miss Brenda Dixon ask her question, and then we have a follow-up question from Minister Brower.
Yes, thank you. Thank you. This has been so helpful and so informative. Some of the churches down in the north and net part of the peninsula have closed their doors again. They're going strictly Zoom. So I'm just wondering, what are your ideas on this? What are your thoughts on this? You think that's a good thing, or you think we need to do more education to encourage people to open the doors? Do we need more information?
I think my thoughts on that are, I can't speak to what's happening in Northern Neck and what they're, I can't speak to what situations they're facing that make them feel not comfortable with opening their doors again. I think there are things that churches, I mean, larger faith groups, doesn't have to be a church, can put into place, such as ventilation, encouraging folks to stay vaccinated and be tested and things like that, stay home when you're sick. There are things that churches can do to mitigate risk. I don't know specifically what's going on there that they don't, it's entirely possible that they're a closed space and they have no control over the ventilation, and it's going to be sitting in a closed room with, 40 other people, and they can't change it, so they don't feel comfortable. There are possibly things that make it less safe for them. I just know that there are things that may be possible to increase the comfort level, increase the safety level so that they feel better, so that a church can feel better about it. It just has to be, individual churches just need to take into consideration their factors and their risks for their parishioners.
I'm going to ask Dr. Fowler, who's also a minister and affiliated with several of the churches, if she has any comments, or can you tell us what's happening at some of the churches that you're affiliated with? Are they going back into in-person, or are they closing their doors? And do you have any idea why they are or are not?
I think, as was just mentioned, it's an individual decision with the leaders of the church and the parishioners, because there are some churches that are open. And to be honest, the church that I attend, I walked in and they're not even wearing masks. And then there are other churches that are spreading out and they're doing social distancing and they are wearing masks and they're having service. So it really depends on the congregation and what they're thinking. Most of the churches are doing both. They're doing online and in person. So you'll see half of the congregation in the building and the other half doing it from home.
And then Minister Brower has an interesting question. I'm not sure if it was answered by Dr. Viray, but do either of you know of a case of long COVID that occurred after a person got vaccinated and wasn't thought to actually become infected with the coronavirus SARS-CoV-2?
Yeah, I think Dr. Fowler spoke to that. We spoke to that a little bit, in that unfortunately vaccination doesn't avert or prevent long COVID if you do have a breakthrough. We spoke about breakthrough infections happen, and the vaccine's good at preventing severe acute disease. We don't have data yet to support, there's conflicting data in the literature on whether or not it averts long COVID. Dr. Fowler, I know you can speak to patients you've had on both ends, the unvaccinated and the vaccinated, and it sounds like the one individual vaccinated, long COVID, COVID again,
Yeah.
and has
Yes.
just had a really rough road. So I think it really runs the gamut. And I think, you know, in no way do we feel like the vaccination is attributable to the long COVID, but it's just that we don't have good data yet that suggests that it is in any way impacting whether or not an individual with COVID gets long COVID.
Okay, I think that that you answered his question as I understood it, but I'll have Minister Brower unmute himself and make sure we have answered his question.
Absolutely. Thank you. I appreciate it.
Did we answer that question?
Yes.
Okay, all right. So we're past the hour now. Just a reminder that the Virginia State Conference is still not posting information on our website or our social media platforms. So I will take this video and post it on the website for our medical ministry, drhamiltonstubbs.com. I can put the video there. It'll be on the website. Just go to the section that says videos at the top. You don't mind listening to a bunch of videos about sleep and how to be healthy, you'll find the video there. Later on, when we have our nonprofit, the Childproof the World Foundation's website working, I'll move the videos over there. But for now, I know I can put them there, and hopefully the Virginia State Conference will have things worked out and we'll be able to put some of this information on our website. Don't forget to look for your information about the convention that's coming up. I'm going to need some help with that workshop, and in general, we just need people to help us with managing the Zoom. I also want to remind you of the challenge, if you'd like to take it. It's the 30 days of eating oranges, and you'll be getting information about oranges. Oranges is something that is delicious. It boosts the immune system. And until I started looking into this, I didn't realize that most Americans have a very low level of vitamin C. And vitamin C is not going to protect you from monkeypox and COVID. I don't believe that, so don't misunderstand me. There's no evidence that eating an orange is going to protect you, but eating a healthy diet is going to help your body with whatever we might be facing, because, hey, there's more things out there than COVID-19 and monkeypox. So we want to be healthier. We want to try to reduce health disparities, and we can do some things at home in our kitchen, and we're going to be learning about that. So if there's no other questions or no other business, I want to thank our speakers for coming. We had some excellent presentations tonight. I thank you so much for sharing your—
I'm sorry, Madam Chair, but I'm sorry, this is Deborah Brown. I do have one question. I'm actually going through a breakthrough of COVID. I am vaxxed and boosted, and I went on vacation and came back 2 weeks ago with COVID. So I was just wondering, is anyone actually tracking which vaccine is seeing the majority of cases in terms of breakthrough? And I'm also seeing that the president and Dr. Jill Biden also have COVID twice. So I'm starting to get a bit concerned because I was very cautious on vacation, but as someone has mentioned, many places you go, in a lot of these states, nobody seems to have a mask on.
I think at this point, there are still efforts to track what vaccine effectiveness is after particular combinations of vaccine. But one of the things that we're running into is that folks are getting a primary series with one, they're getting boosted with another, and sometimes they're getting boosted a second booster with the other. Like they'll start with 5. I do think the mRNA vaccines, Pfizer and Moderna, for overall do seem to be tracking along the same lines compared to, say, the AstraZeneca that isn't available here, the Johnson & Johnson that people don't have much uptake here. But I don't know that I have seen anyone, because it's a little complicated. There's a lot of follow-up, but how we're doing overall like the mRNA vaccines are doing overall compared to like the AstraZeneca vaccine platform and things like that. But and so it gets a little complicated simply because there's so much mixing and matching at this point. We really just want someone to get another mRNA booster. And so it's not, I can't say whether or not Pfizer is doing better than Moderna, simply because I don't, at this
And
point.
that's what I was curious about, because I had all Moderna all throughout boosters and vaccines.
Yeah, we're not seeing a straight up difference between Moderna and Pfizer as much as we are like between the Moderna, Pfizer, and like other platforms, if that makes sense.
One of the things that I noticed is people no longer wear the face shield unless you're in healthcare to protect your eyes. And some of these infections, depending on where you are and who you're around, it may have been that you got it through a different route, maybe through your eyes, or is your mask appropriate, or are you wearing a mask that doesn't give you much protection, and you get more protection if both people are wearing a mask? So I think there's a lot of reasons why we could still get infected, even when you feel like you've taken all the precautions.
It's really true. It is about how much virus is around. So the more people you have who are infected in the vicinity, the more likely that you're going to run into some sort of droplet or aerosol or come into contact with something and touch your face by mistake. It just matters how much, how many infected people you have in the area. How many overall, not in a certain room, but like, in the community, the more folks who are infected overall in a community, it's easier to acquire as we go out in the community. But you decrease your risk by, the good hand hygiene, the mask wearing still decreases the risk, even more so, as Dr. Hamilton-Stubbs mentioned. If both people are wearing a mask, it was never going to be 100%.
I'm going to end with this last question from the chat. Do you think, you or Dr. Fowler, that the monkeypox vaccine will become mandatory, just like our children have these mandatory vaccinations they have to take if they want to go to public school?
Hard to say. And part of that is that we don't have the supply to just make it mandatory right now. And so it will be a process to it. So it's really hard to say what will be the final word on that. There's no discussion right now about making it mandatory, and we will find out as time passes.
Yeah, I agree. I think also that we're not seeing it. It's not, what COVID did is it started in one place and it went everywhere. It did not judge by age, by gender, by any population, by any specific, it was everywhere. And that is different from a lot of other things. So a lot of vaccines we give out to the at-risk populations. We don't give out to everybody, unless it becomes a point where the preponderance of the evidence says that this is going to protect the majority of people, and that's why we need it. And I don't think we have that evidence yet about monkeypox. I just suggest that that's what we need for monkeypox.
Well, this has been very interesting. We thank you both. I know we could go on and on because the questions just keep coming. So don't be surprised if I ask you both if you come back again sometime in the future when we are looking at maybe the next variant or more information on monkeypox that we need to get out so people can just live, but live according to what we have to do now to protect ourselves. We can't be afraid to change. If you don't change, you will not survive. You will be like the dinosaurs. So we have to change as our situation mandates. We just don't want to act out of fear. We want to act with knowledge and use our faith, but not foolishly. We're not here to test God. We're here to use the resources. And the resources that He's given us are abundant, including Dr. Fowler and Dr. Viray. So thank you, ladies, both for being here and the work that you've done and will continue to do to help the community and really to help our country make it through this crisis, this historic moment. Thank you all for being here. I thank the health committee. I couldn't do it. There is no committee of one. We have 36 people from the health committee, and a lot of them made it tonight. Thank you, thank you, thank you. Go in peace. You've been a blessing. I hope that we can all be a blessing to someone else. May God bless you more. Good night.
Thank you.
Thank you.
Good night, and thank you.